Welcome, curious minds. Today we're doing a deep dive into something pretty fundamental.
Hmm.
What justifies a field of study, especially in health?
Yeah, what gives it a reason to exist? It's warrant, right?
Exactly. For, say, biomedical science, it seems obvious. Improve health,
Yeah.
stop people getting sick or dying. Pretty clear warrant.
Sure.
But what about health sociology? Does it need its own justification? And specifically, qualitative health sociology, the kind that really gets into people's actual experiences, where does its value lie?
That's the core question. Some sociologists work in medicine, trying to make healthcare better directly. Others study the sociology of medicine more for academic understanding. But the article we're looking at today by Stefan Timmermans argues qualitative health sociology has this really distinct, critical job.
Which is?
To kind of step back and reflect critically on health itself, challenge assumptions, reveal stuff that usually gets ignored.
Okay, let's get into that. How looking at lived experiences changes how we see health. What's the first warrant Timmermans talks about?
Right. The first one is about illuminating how medical beliefs are constructed.
Constructed, meaning they aren't just facts.
Well, yes and no. It means asking how we come to understand things like health or disease or treatment. It shows that what feels natural is often shaped by social factors and history.
Okay, like an example.
David Armstrong's work on health behavior is a great one. He traced where that idea came from.
You mean like eating well, exercising?
Exactly. That idea of it being your choice, your behavior, it wasn't always seen that way. It evolved from, believe it or not, terms describing how objects move to this modern idea of patients making autonomous decisions.
Wow. So the focus on individual responsibility isn't timeless.
Nope. It shows it might have been otherwise. It's a product of its time.
That's really interesting. Okay, so questioning beliefs. What's next?
The second warrant is witnessing health victories and losses.
Witnessing, like just observing.
More like documenting both the amazing things medicine achieves and the suffering, especially for groups who are often overlooked.
Ah, okay. Like the intersex activism example.
Precisely. Social scientists worked with advocates, and they documented the serious long-term harm from surgeries done on babies with ambiguous genitalia.
Harm that wasn't really acknowledged before.
Right. The research gave people a voice, showed their experiences. It highlighted how those medical decisions were often more about fitting social gender norms than actual medical need. So it reveals the hidden side, the costs.
Got it. So sometimes things don't work out as planned. It sounds like the next warrant. Unfulfilled promises.
Exactly. Documenting the gap between what an intervention promises and what actually happens in real life.
Like the newborn screening example.
Yeah. Screening for PKU was a huge success initially, so they expanded its screen for dozens of rare diseases, promising to save all these lives.
It does.
But the follow-up studies found it wasn't so simple. Parents faced huge uncertainty, results weren't always clear, kids ended up under intense medical watch.
Without clear proof, it was always saving lives as promised.
Kind of. It showed that just having the test isn't enough. Success depends on the whole healthcare system around it. The promise wasn't fully met.
Okay, that makes sense. What about following the money? That sounds pretty direct.
It is. It's about understanding healthcare stuff by asking, basically, who's making money here?
How does that help?
It can reveal financial motives hidden behind the language of care, like Renee Almeling's study on egg and sperm donation.
What did she find?
Egg donors get paid way more than sperm donors. Significantly more.
And it wasn't just biology or availability.
Nope. The interesting part was how it was justified. It tapped into cultural ideas about motherhood being more involved, more giving than fatherhood. So a higher price tag on the woman's contribution. Money ties into cultural beliefs.
Huh. Okay, next is intersituationality. Bit of a mouthful.
Yeah. It just means looking at people in different parts of their lives, home, work, leisure, not just when they're in the hospital or clinic.
Why is that important?
Because health and illness happen everywhere, right? Daniel Chambliss studied nurses ethnographically. He found bioethical problems weren't just random ethical dilemmas.
They weren't.
No. They often came up systematically from conflicts within the hospital structure, power dynamics. Nurses were often caught in the middle, so labeling something a bioethical issue could sometimes be a way to avoid dealing with deeper systemic problems.
Shifting the focus. Okay, what about causality and social mechanisms? trying to explain why things happen.
Exactly. Moving beyond just describing to explaining how causes lead to effects, often through specific social processes.
Like the study on surgeons' work hours.
Yeah, Catherine Kellogg's study, lots of hospitals just said, yep, we cut the hours, but didn't really change much.
But one place actually succeeded.
Right. And why? Because reformers inside created this space where clinicians could share struggles, plan together, build support. It wasn't just policy. It was what Kellogg called collective combat. People actively working together made the change happen. The mechanism was social.
So the how matters as much as the what. Okay, last one. Reframing dominant perspectives.
This is about developing ideas, concepts, theories that catch on more broadly, maybe even outside academia, and offer a new way to see things.
Like a medicalization.
Perfect example. That term is everywhere now, right? Used by researchers, activists, journalists.
Yeah, meaning turning normal life stuff into medical problems.
Pretty much. Or at least questioning when that happens, often unnecessarily. The concept itself gave people a language, a lens, to critique medical expansion and think differently about what really needs a diagnosis.
So, wrapping this up, what's the big takeaway here?
For me, it's the critical power. Qualitative health sociology isn't just observing, it's questioning, digging deeper.
Yeah, it shows that our understanding of health isn't just there. It's built, it's contested.
Exactly. These warrants, by focusing on real experiences, push us to ask about the assumptions, see the hidden costs, track the money, understand a context, find the real causes.
And even change the very language we use to talk about health. So maybe the final thought for you listening is, next time you hear a health claim or encounter some medical practice, just pause. Ask, what's assumed here? Whose story is being told and whose isn't?
That kind of thinking, that critical lens, really helps us navigate the world of health more thoughtfully.
A fantastic point to end on. Thanks for that deep dive.